Hi, everybody. This is Mike Grillot. I'm one of the orthopedic hand surgeons at Valley View with Valley Ortho. We're going to give a talk on thumb pain tonight. If you have any questions, go ahead and put it on Q&A. That's the key thing here. I'm not a big Zoom person, but I have plenty of help with Maggie and Sarah. They're going to help us with questions, and if I kind of goof up, they're going to redirect me, keep me in line. What we're going to do is kind of go over all the different things that could hurt on the thumb side of the hand and wrist. And remember, question and answers at the end. And I'll try to answer them. The rule is that you have to ask me a question that I know the answer to. But if you're really good and you ask me a question that I don't know, then we will email it to you later. So we'll get the answer for you if I don't happen to know it. I kind of, let's see, we're going back one page. I'm going to try to go back a page if I can. It's kind of going slow. We tested this earlier, believe it or not, and it did work. So my page is not working. So let's take a peek. So let's take a look. So where are we going? Escape. Let's look. So I try to do these. Can we go up? It's just going to continue to go. Keep going. Is this where it starts? All right, so I'll just click these guys. We're going to do a little reverb here that they're leaving the room. So for some reason, it won't let me advance the page. But my first page, I'm just kind of go over the summary of what we're going to be doing. We're going to go over causes of different kinds of thumb pain. And then I kind of, when I have patients come in, I look at layers of tissue. You got skin, and then you got right below the skin, you have nerves that give feeling, sensation, and they also send muscle branches. Well, those can make things hurt too. And then below the nerves, we have tendons. And then below the tendons, we have ligaments, and the ligaments are part of the joints. And then a big part of the talk will be on the arthritis or osteoarthritis, which is wear and tear of our joints. And then we'll kind of go over how to diagnose it, treatment options, and then we'll have questions at the end. For the nerve that goes to the thumb side of the wrist and hand, it's really just one nerve. It's called the superficial radial nerve. There's a little overlap of another one, but this is the main one. And it kind of comes out between two tendons right in this area here. And it's, believe it or not, that nerve can actually be inside of a tendon that can pinch on the nerve, and it kind of scissors between them if that's not the case. And it'll make it hurt right down, right by the thumb. So we always kind of look to see if there's reasons that may not be bones or ligaments or tendons, and it can be the nerve. For the superficial radial nerve, there's really two spots that can be a problem, but the diagnosis is usually numbness over that area. If a nerve gets squished and it's a sensory nerve, it's going to make it feel numb, tingly, and you'll have some burning pain. Where we can find where that feeling is, where it's getting compressed, is we have a test called the Tennell sign. And a guy named Tennell described it. But what happens is if you tap it on the area that it's pinched, it'll send a shock down towards the fingertips or the thumb tip in this case. So that kind of lets us know where the problem is. And if it is the problem, we have to feel that area to make sure it's not numb. For treatment for superficial radial nerve pain, in the mid forearm, therapy can help. They can loosen up the tissues around there and make it feel better. If that doesn't help, we can try a little steroid shot in that area where it's getting squished. And if that doesn't help, we have to open it up surgically. So we just find out exactly where it hurts the most, numb up the area, or have people get sleepy when we numb it up. And we go in there and just open that covering up over the nerve. At the wrist level, it can be right in this area here. It can be as simple as using a wristwatch too tightly. And For that, we just want to take the pressure off the nerve, and therapy is our mainstay for this. Going in there and trying to take the pressure off by just making an incision over the nerve usually creates scar. And we don't like scar on top of a nerve. That'll just make it worse. So on the wrist part, we just try to keep you from putting pressure on it. For tendon pain, we have several tendons that go towards the thumb. This one here, the extensor pollicis longus, it helps straighten out the tip of the thumb. These two down here, one of them helps bring the thumb out of the palm, and the other one helps straighten up this part of the joint. And it can get squished right in here, it can get squished here, but this is what we're going to talk about. And it was so common, a guy named De Quervain described it, and it's a huge name, so I wrote it out for you. De Quervain's is where there's a tight squeeze in the wrist, pushing on two of the tendons that help pull the thumb out of the palm. When we see this, we try to decide where it might be coming from. It can be from one of the two tendons, but a lot of times we can't tell. And the most people who we see it on are actually new moms. So they get picked on, you know, when they have babies, they get De Quervain's, and when they're pregnant, they have carpal tunnel syndrome. It's kind of not fair, but whenever they're holding the baby or when they're breastfeeding, a lot of times they'll bend their wrist in a position that just puts pressure on it, and it just makes it tender. How we diagnose this is we put pressure right on this area of the wrist, and that usually is tender. Sometimes they'll even have some thick tissue over the top of it, and you can kind of feel it right under the skin. And then just as De Quervain's is a tough name, there's a guy named Finkelstein that described a test where you bend the wrist and kind of push the thumb down, and it'll hurt right in this area. So they get great big names on this really common problem. For the treatment, when it's really mild, we put on thumb braces that go across the wrist, and it supports that area that keeps it from moving. I find that that doesn't work too well unless it's really mild. For more severe cases, we put a little steroid shot in there. And that steroid shot, we may try once or maybe twice to calm down the inflammation in there. If it doesn't help after probably 2 shots, then we operate on it. And when we operate on it, what we do is we go down and open the covering up over those tendons. And a lot of times we'll find a little septum between them that we have to kind of clean out to make sure it's freed up. And this is just an example. I don't know if you can see that, but it's an example where we just go in there and open the covering up. We close the skin and improve it just by taking the pressure off. It usually takes about 4 weeks to 6 weeks to get over it. Every once in a while, you'll need therapy. So the next one is on the palm side of the wrist. And this is kind of interesting. What happens, there's a tendon called the Flexor carpi radialis that goes right next to a little bone that sometimes will have arthritis, and it can get rubbed on right in this area. And this is on the palm side. And we call it Flexor carpi radialis tendonitis. And it's on the palm side. It's usually associated with a little bit of swelling and tenderness right at the base of the thumb going down into the wrist area. So it'll be hurting right in this area here. For that, it's usually caused by a rough edge on the trapezium, and it's a tight squeeze in there. So the treatment for that is trying to use a wrist brace if it's not too bad. We put a steroid shot in there. We try to put that shot right in this area here so it calms down that inflammation in there. And believe it or not, this sounds crazy, but we try to put that shot in there to calm it down, but also that tendon can be almost ruptured or partially ruptured, and sometimes that tendon pops. And when that tendon pops, it's actually a good thing because it usually gets rid of the rubbing tendon, and it's just a piece of tissue in there. And that sounds crazy, but actually having that pop can relieve the symptoms. It's a horrible way to think of it, but putting that shot in there sometimes will soften the tendon enough that it'll pop. If those injections don't help, a lot of times we'll go in there and just open the covering up over those tendon into the wrist, going down into the forearm. And then sometimes if it's really inflamed, we'll just cut the tendon out. And I'll tell you a little bit later about that tendon. A lot of times we use it for tendon transfers, especially for arthritis in the thumb. And we use the whole tendon, and people just don't seem to have any loss of function. So on trigger thumbs, this is another thing that creates pain, and that usually people on their very last part of the joint, when they bend it, it'll pop. It'll click and pop, and sometimes it locks down. And it's usually worse in the mornings because when we sleep at night, the fluid in our legs, when we lay down, we'll spread out in our hands, and it'll make our hands puff up a little bit. So usually 3 or 4 in the morning, when it'll start getting tight, and people will wake up with their thumb tight in the middle of the night, and sometimes in the morning it'll be kind of locked up, and then it loosens up through the day. Usually locks when you have the thumb bent. Here's an example of where it's tight. It's right here at the base of the thumb, and it's called the A1 pulley. There's several pulleys in there, but this is the guy that messes with it the most. And it usually gets bumped right in this area so much that it makes a bump on the tendon, and it kind of locks it in or out. As you bend the thumb, that tendon moves back and forth. It's just a big leader where the muscles pull down, and that leader can get rubbed on and make a bump on it, and that's why it clicks back and forth. What we do for it, one of the cool ways to take care of it is just to tape the end of the last joint on your thumb. Tape it when you sleep at night. What that does, it keeps it straight, and it seems to help. It may take several months for it to help, but it really does make a big difference. Another way to take care of it, makes it a little bit quicker to recover, is to put a steroid shot right in the area of that A1 pulley. So we'll see if we can go backwards. So that A1 pulley is right here and right here. So a lot of times we'll put a little steroid shot right in this area. That medicine trickles away over about a month. So I'll repeat that shot twice. So I'll give up to 3 shots to see if we can cure this without surgery. And for me, 75 to 80% of the time, it can get cured without surgery. But if that doesn't work, then we have to go in there and open the covering up over that tendon. And I'm going to show you a picture of what it kind of looks like. We just make an incision. For me, I just make a little V-type incision. We go in there and open the covering up, and this is an exaggerated picture. You know, we usually don't pull it out of the palm like that, but that shows the really pretty shiny tendon, and the covering was sitting over that made the bump. On one around here that we'll see a lot is skier's thumb. And what happens is the ligament at the base of the thumb will get torn, and it occurs when people fall down, you know, on their ski pole. There's different grades based on how much of it's torn, and you can kind of tell by exam how much of it's torn based on how loose it is. There's a person by the name of Stenner that got his name on it, that when you have a complete tear and it gets displaced into the soft tissues where it has no chance of hooking back to the bone, that's called a Stenner lesion, and those need to be repaired. So on a skier's thumb, you can kind of see here as you fall down, it'll tear that ligament right in that area of the thumb. An example, I got 3 examples here that shows what happens. They recommend putting your ski glove or your hand up through and then back down onto the pole. That way it'll make it easy, it'll make it less chance for it to get torn. This is an example of having it go in from the top down. If you bring it in from the bottom up and then kind of grab the straps as you put it on there, it'll make it a little bit less chance, but I think people still tear their thumb. And this is an example of a Stenner lesion where there's this soft tissues that'll get in the way, and that little ligament will get torn and it'll get popped back into the soft tissues away from where it came from. For the skier's thumb, it's usually at the base of the thumb. It's right here. There's looseness to the joint, and we always have to compare the injured hand to the non-injured hand. Now around here, everybody injures both hands, and some people don't need to ever get it fixed. So it's kind of hard to fully decide if somebody's torn both of them and one of them is now a new injury. But usually if it's really, really loose where it can kind of crank out really far, or at least 15 degrees more than the other thumb, then it's usually a complete tear. And x-rays sometimes will show a broken bone. A lot of times this will pull off a piece of bone with it. And here's an example of where they super stretched it out to show that this is completely torn. And I don't usually do that, because if you have a completely torn ligament, but it's in the right place, if you were to pull it out that far, it's going to push that piece of tissue in the wrong spot. So that person could have made this thumb much worse by pushing it that far. And this is another example of that Stenner lesion where it gets popped into the tissues around the side. And another example here. These have to be fixed. So on the treatment for partial tears, I usually splint them in 3-week intervals, because if it's barely torn at 3 weeks, these can get a whole bunch better. When they're completely torn, I like to protect them for at least 6 weeks before we do too much other than just doing a little bending. So we have a splint on that protects the ligament, and you take the splint off, and then you just work on gentle bending slowly. They've shown that a little bit of movement on a ligament makes it heal much stronger. And then you slowly progress your improvement. The problem is when it's a complete tear and it's really loose, we don't know if there's that stentor lesion where it's in the soft tissues away from where it belongs. Unless there's a little chip of bone with it, you can kind of see it on x-ray. But there's two ways that I do it. Either we get an MRI. MRI is the most accurate to look for it, to see if it's completely torn and displaced. Or if you want to stay away from the cost of an MRI, we'll put it in a splint and then check it 3 weeks later and to see if it's getting stronger. And if it does get stronger and we're moving it and there's a good endpoint, then we check it another 6 weeks or another 3 weeks and in 3-week intervals to see if it gets stronger and stronger. But there's some folks that just need to know today if it's torn. So we usually order an MRI if it's really loose. And again, if you have a stentor lesion, we repair those. Those are not going to heal. For the surgery, we just go in there, make an incision right in this area here. This is what a normal ligament looks like on the side of the thumb. It's kind of a crude x-ray or picture, but we go in there and make an incision, open that up, bring that yellow flap back down to the bone, and then we usually put an anchor in there to tag it where it belongs. These anchors have sutures in them. This is the one that I kind of like to use because it has 2 sets of sutures that really grab that tissue and tag it down. That anchor is deep in the bone, so it's really not going to cause, it shouldn't cause any problem. And the sutures come out there and tag that tissue down. So this is something that we have to do quite often, but a lot of times these can heal without surgery as long as we don't have that stentor lesion in the wrong spot. For bone and joint pain, it's really the joint. So this is something that probably the main thing that I want to talk about is, because I see it every day, is osteoarthritis, which is wear and tear on our joints. There's different joints in the thumb. The interphalangeal joint is the tip bone. Go back. The metacarpal phalange joint is right in here, and that's the one that has that skier's thumb. It can have arthritis in there also, but the carpometacarpal joint is a great big word for the base of the thumb. And this is kind of the one that I wanted to focus on because I see it every day. So for the interphalangeal joint, this is an example of someone that has a lot of arthritis in their fingers. Tip of the thumb is the interphalangeal joint. On the fingers, it's the distal interphalangeal joint because they have more bones in there. They think as we evolved, the bone right in here used to be a metacarpal. These are metacarpals here. Well, this one is just a short metacarpal, and it's a finger. So, but everything rotated side, to the end of the palm, which made us be able to grasp things much better. But so for the thumb, it's an interphalangeal joint that has arthritis. Here's the metacarpal phalangeal joint and the carpometacarpal joint. So for the interphalangeal joint, metacarpal phalangeal joints, for the thumb, we usually fuse them. The thumb is a really good post to grab things. If these are really bad, we try injections, splinting, tape to try to calm it down. If those don't last very long and that doesn't help, then we fuse them. And I'll give you a couple pictures. For trying to keep you from getting operated on and give you relief, you can try non-steroidals, which would be like Aleve or ibuprofen. You can also take Tylenol, which can help with pain. And I'm a big fan of Cosamin DS. Cosamin DS is glucosamine and chondroitin sulfate. It's one of the only brands, it's a name brand. It's one of the only brands that actually does have research. And it's the brand that supplies the veterinary businesses with animals. And, to be honest, an animal has no idea what they're getting. So if it doesn't work, there's no placebo effect. Either it works or it doesn't work. So it does work for animals, and it works for probably 75, 80% of my patients. It seems to calm down the inflammation, and it's the building blocks for cartilage, and it may maintain some of that cartilage over the long run, and it could keep you from having to be operated on. And again, we can do steroid shots periodically. I like to wait at least 3 to 4 months. If we do shots, you can repeat them really forever if you want to stay away from surgery, but you want to wait a good 3 or 4 months. 4 months is a better number for all the tissues to recover before you put another shot in. What you're doing is you're trying to calm down the inflammation. You're not curing it at all. So you just want to calm that inflammation down. I idea is that if you wait 4 months, all those tissues recover back to normal before you reintroduce a steroid shot. For these long-acting steroids that we put in there, it usually aches for a couple days and it takes about a week for them to kick in, but it does help. And if these all don't work, then we fuse them. And I'm going to give you a couple examples of what fusions can be done. This is that distal interphalangeal joint. What they do is they take out the rough bone, good bone-to-bone contact, and put a couple pins in there, or they can put a screw down this. This is an example of the metacarpal phalangeal joint, and this has a couple of screws in there to hold the bone. And this is an example where you can use pins and wires. Both of these work really well. I've done it this way forever, and recently I've started putting screws in that really holds it well. It seems to heal it well. So I'm kind of the screw champion at this point by putting a couple screws across that bone, that joint. Those usually take about 10 weeks to heal. I don't know if I've had any that didn't heal, but it can take longer. For the carpometacarpal joint, that's the guy right down in here. It's one of the most common joints in our body to have arthritis. I see patients every day with this type of pain. It's shaped like a saddle. It kind of curves this way and it curves that way. And then everything we do, everything we grab, we use our hand, and it can make it irritated. Women have a lot more problem with it, and they think it has to do with a loose joint. So women just have more loose joints than men, and they have a problem with arthritis at the base of the thumb, probably because of that. We make the diagnosis usually just by x-rays and exam. Usually it's right at the base of the thumb, right down here, and you'll have cramping pain that goes towards the metacarpal phalangeal joint, probably from these muscles. It'll refer pain right up to this area, but the pain is right at the base of the thumb. We have different grades of arthritis. The first grade is where the joint just kind of gets open and there's no widening. This is one where the joint is wearing down. This joint's worn down right in this area, and this is like the second grade. There's little spurs that come off. This is called the trapezium bone, and this is the one that's kind of the mean guy that causes all the problems. You can see spurs going that way, this way, and there's a little bit more narrowing, and it's a lot brighter in color in this area. That brightness that they think has to do with when the cartilage wears out. The slippery part of the cartilage is a cushion, but it's also slippery. When it wears out, it puts more force into these bones, and they get brighter. And when they get brighter, it's very obvious that you can see it, and the joint space gets narrow. When it gets worse, this trapezium bone here has arthritis in here, but it'll have arthritis on this side and that side. And that's the third type. That's kind of the worst, is the worst case. So you can kind of see there's a pretty big space here. This one here is worn down where it's arthritis on both sides. So for treatment, I'm a huge fan of bracing. Sometimes that's all you need is a nice brace. The therapist at Aspen Valley Hospital and Valley and I work at both in Aspen and in Glenwood Springs, but the therapists in our valley are super good with having braces, and they actually have different kind of braces. Some of them are over the counter. Sometimes they have to make them, but at Valley View, they have about 3 different braces that support the thumb. And a lot of times we'll have you go to the occupational therapist, and they will fit you with the brace that feels most comfortable to you. And then they have a really good exercise program. And the theory is that if you balance all the muscles, they line up appropriately, and it really can make a huge difference on how strong your pinch is, and also make sure the bones don't shear out, kind of shear in the wrong position. For treatment, again, Aleve, Tylenol, and Cosamin DS, again, is my favorite. For the surgery, there's a whole bunch of different ways to take care of it. And what's amazing is that they've done long-term studies with all of these different ways of treating it, and they've found that they're all about equal. So then you have to decide, how mean are we to the patient on how much do we do surgically to disrupt their tissues, and then how long do you think it's going to last as far as the surgical procedures. And then there's another thing that we do. I'll show you all the different ways, but it's pretty complicated area. It seems pretty straightforward, but you got that superficial radial nerve. There's some tendons in the way. There's even blood vessels in the way. But this little guy underneath here is where all the business is. This is the trapezium. And for most of our surgeries, we either take part of that out or all of it out. Again, this is going to be one of our pictures that we talked about before, but that trapezium is kind of deep in there. There's a little branch of the radial artery that sits in there. We kind of have to move out of the way. And then there's some tendons in the way and a capsule that we work on. So this is an example of arthritis of the base of the thumb. One of the ways you can treat this is you can fuse it so it doesn't move anymore. I'm not a huge fan of that because if you fuse it, your thumb doesn't move down here anymore. It'll just do this. And also when you do that, it puts more pressure on this, what we call the scaphotrapezio-trapezoid joint. So it may put so much pressure there that you may develop arthritis in this area. And this is an example of a plate that was put in where they fused the trapezium bone right here to the metacarpal of the thumb. So this is just a plate, metal plate with screw holes, and each one of these screws goes in there to hold it in place. And that's called an arthrodesis or a fusion of the thumb carpometacarpal joint. It's a lot easier for me to say CMC joint. For some docs will do a partial trapeziectomy, and they can actually do this through an arthroscope, and they'll go in there and make little incisions, and then they'll grind off this part of the trapezium, and they'll have a space in there. This is an example of what you can do. So this patient had arthritis here. This is not my patient. I just stole it from the internet. They take part of the bone out and then they pin it. Sometimes they'll even put a little piece of tissue in there. And that'll be a tendon that can be harvested in the forearm and the wrist. This is an example. What happened later is it just kind of fell down. So it didn't support it very well. So I'm not a huge fan of just taking part of it. I've had to redo quite a few of these where I came from in Missouri. There would be a doctor in an outlying area that would do this a lot. And then they would come to me and I had to take the rest of the bone out and do some tendon work to protect it. Another way that is treated, which is kind of cool, is you just go in there and take the complete bone out and then you pin the thumb metacarpal to the index metacarpal. And what you do is you allow all this tissue to just kind of scar in, and you pull these pins out at about 6 weeks. So when they started doing this procedure, I thought, okay, this is the least traumatic way to take care of this problem without stealing tendons or putting tissue in there. So I wanted to follow it. So I followed it for about 13 years to decide whether that was a good way to treat it. And they've had really good results. In fact, the results are just as good as all the other fancy tendon work and arthroplasties and all this other stuff. All they do is just take the bone out. And at 13 years, the last article I read showed it have really good results. And you just take the bone out, put pins in, 6 weeks later, pull the pins, and then let people use it all they want. Some people will even pull the pins at 4 weeks. There's some people that don't even put a pin in, but I think I'd probably do it at least 4 to 6 weeks. I have not done that procedure. Here's an example of what we would call the home run shot. This is where you do everything. And originally when they went in there and took that bone out, they let people just use it right away, and it became really unstable because there was no support. So they went right from just taking the bone out to this. And what they do is that flexor carpi radialis tendon that we were talking about earlier that can get rubbed on, what they do is they go in there and take the trapezium out, and this tendon runs right next to the trapezium, and you steal the whole tendon. You release it down here in the forearm, and then you pull it up through the incision that you have right down here. Then you go in there and then put it through a little drill hole in that thumb metacarpal right in this area. So they go in there, put the drill hole in, they pull the tendon through there, and then they pull the tendon back where that trapezium was, and then they just fill that space and then close the capsule. When you do that, that was my favorite way to do it because you're just trying to take care of every potential problem. You're kind of recreating a ligament here, and then you're recreating kind of a cushion here. So it tries to prevent that bone from drifting down, bumping into the bone called the scaphoid. Interestingly, almost everybody, no matter if you do this and fill it up really tight, almost everybody, that thumb bone metacarpal always seems to drift down. And they've looked at the tissues in there. It really doesn't have blood flow. So when you push that in there, it just turns into kind of a glob of nothing. It really doesn't revascularize or anything. So you have to really rely on this capsule right in here that you have to re-repair to hold everything in position. So it's a great way to do it. It takes really long time to get better. I usually protect them for a good 3 months before I let people go doing their activities. But it's a great way to do it. It actually creates drill holes. You're stealing a complete tendon. I found that taking the tendon, it doesn't seem to be a problem. So remember we were talking about before, the flexor tendon that gets irritated in here, you can just release that. And if it gets out of the irritated area, the pain goes away. So we can steal that tendon with no physiologic impairment at all. It's really cool. This is an example of a fancy piece of material that they call a tightrope. And what you do is you take out that trapezium, it used to sit here, and then you drill a hole here and drill a hole here, and then you put a suture in there that's tied around these little buttons on each side. It kind of holds it up in this area. I've personally had to take care of ones that didn't do well, and sometimes this bone right in here will break. So I'm not a big fan of this procedure, but a lot of folks do it this way. The advantage is that you get going really quickly because you're just relying on this suture, and so you close that capsule back down, and you can get people going fast. This is an example from their company website that shows how kind of pretty it is. But I'm not a huge fan because it can break the bone. They've made the drill hole smaller, but I'm still not convinced that it's the best way because I think it really pushes these two bones together too much and you can develop a little bit of arthritis in that area. So through this to be complete, you can have a true arthroplasty. They have certain arthroplasties that kind of recreate the joint in this area. This is, I don't know if they still use this one or not, but it just allows you to rotate the thumb with actually just a kind of curve in the bone. And this is the trapezium that we talked about before that we usually take out. I don't do that surgery, but I know there's some guys around here that may do that, and they seem to have pretty good results. If it fails, these are really hard to get out, just from history. The way I like to do it, so I saved it for last. After seeing how they do that in California, where all they do is take the bone out and put pins in, I thought, well, gosh, that's cool, but I'm not sure if that's the long term, if that bone is just going to drift down to the next bone. So I do a simple thing that's just a suture sling. So what we do is we take out that trapezium bone and we put stitches from one of the tendons that hooks into the base of the metacarpal of the thumb to another tendon that hooks into the base of the index metacarpal. And we just throw about four little stitches across there and suture it up. And what that does, that makes a little cot or little sling that supports it to try to keep it from running into the scaphoid bone. And I've had really good results with this. And I think for me, it's a better procedure than just leaving nothing there. I would rather have a little stitch in there than nothing. And I've had good results. The recovery is quick and I don't steal any tendons. The downside is that this one tendon, that one that we talked about, that sometimes we'll cut out, it's called the Flexor Radialis tendon. That's one of them we have to stitch into. One of the downsides is that sometimes it'll scissor on that and the tendon can pop. Interestingly, at one of the hand meetings I went to, one of the guys just cuts the tendon after he's sutured this together. So then he didn't have to worry about it popping later. And I think if God put it there, then I'm going to leave it there. So I think it's appropriate to probably just try to tie it a little bit tighter in here so it doesn't scissor back and forth and cut the tendon. And as I promised before, we have questions that you can give me, but the thing of it is that you have to let me have a question that I know the answer to, so it's important. Only ones that I know the answers to.
Well, that was great. We just came in with Dr. Grillot to ask a couple of the questions that some of the people have asked on Zoom. So if you have any else, feel free to send them our way and we'll kind of filter through these. But one of the questions was from someone who has a trigger thumb. She thinks she has a trigger thumb. She wanted to know how long she should rest before she kind of gives up on that as a treatment option. I know
I'm on a listserv with about 1,500 hand surgeons, and one of the hand surgeons almost operates on no one. I find that hard to believe because sometimes it locks down and you have to pop it open and it's killing in pain, but he's a Canadian and he says just taping that last joint is the way to go. And a few of the other orthopedic hand surgeons chimed in and they said, well, gosh, we do the same thing. In fact, I've had trigger finger or trigger thumb a couple of times and they'll tape them maybe for a year, but it's really based on how bad it hurts. But the doctor in Canada says he doesn't inject anyone, but I just find that injections really help and they cure it the majority of the time. It may not be the first shot, it may not be the second, but the third shot can really, in my hands, cure it about 75% of the time. So if you're suffering, I'd probably try a shot. If you really want to do it, I'd give it a good 6 weeks. And if you see improvement, another 6 weeks. And if it's getting better, another 6 weeks.
Perfect. That's great. The next two questions are kind of related. One of them says, are there changes in the thumb that occur with age that make it more susceptible to injury? And if so, are there exercises that you can do? And then the second question was, for DJD of the thumb, that carpometacarpal arthritis, are there specific exercises they can do to help it?
Yeah, there are. I don't have them in front of me, but one of them is to do a simple puppet exercise. Let's just say this is the table, and you push down like this, and you're pushing down on the table. You're wanting to strengthen the muscles that pull your thumb away from your hand, and also pull away down away from the hand. So this way, and then this way. And you don't have to kill yourself doing it, but just trying to tune these muscles up right in here, and the ones that bring it outward can make a difference. And I think there may be some examples on the internet. If not, we can, I don't know how we can get you into therapy. We can get you into therapy, and they can really set you up with bracing that you use intermittently. So if you wear a brace all the time, it's going to make it weak. So you're wearing part of the time, like 2 or 3 times a day, or if you know there's something that's going to hurt, you put your brace on. And then if you do those exercises religiously, I really believe they help. It's not going to cure the arthritis, but it may rebalance those bones so they don't hurt as much.
Great. Well, those were the only questions we had. That was excellent. Thank you for doing that. If anyone else has questions that they want to submit real quickly before we finish, we're happy to answer those. Otherwise, you will get an email with tomorrow with a link or with the actual recording. And so if you want to share that, or if you want to send it on to somebody or rewatch it, you're welcome to do that. There's also going to be a survey that we would love for you to fill out if there are topics that you would like to hear from us. We're happy to integrate those into our future talks. The next one is going to be the first Wednesday in September with Dr. Leota. And we do have one more question. Someone wants to know if it's harmful to crack their knuckles.
I've read one study where they said that they could hurt the capsule in the joint, but I've never seen anybody hurt themselves cracking their knuckles. You can crack them all day long.
That's a great.
Okay.
Great. Someone said they missed the beginning. Are you talking about cortisone shots? Yes.
So I can go over cortisone shots. So I use 2 different kinds of steroids. And the cortisone is cortisone. There's a whole bunch of different kinds. Some of them last longer than others. For tendonitis or trigger fingers, I use one that has a mix of the short and long-acting steroid, and it kind of goes away after about a month. So that's why for trigger fingers and tendons and irritated nerves, we'll do a shot like that. And for tendons, if it's all better, awesome. But if it still bothers you in a month, sometimes we'll re-inject it. For joints, we know we're not going to cure anything. So what we do is we put a shot in there that's a really long-acting steroid. And that long-acting steroid actually hurts for about 2 days, and it can take up to a week to really kick in, but it slowly goes away. But remember, we talked about before that if we put a shot in a joint, you kind of want to wait about 4 months before you have a new shot, if you need one, only if you need one. And the reason is to allow all those tissues to recover, but that steroid slowly trickles away. And so I like to use long-acting steroids, hurt a little bit for a couple days. Short-actings usually don't hurt much at all. Usually kicks in right away.
Perfect. Okay, well, I think that's it. So feel free to join us on September 1st for Dr. Leota's talk on shoulder pain and how to treat it. And thanks for attending.
Thanks everybody for showing up. This was great.